Hey everybody, it's Dr. Wood, and today we're going to be talking about statistical tests. So here's the objectives. I'll let you read those as you like. And so here are some of the more common comparisons you're going to be running into when you're reviewing the medical literature. And the first ones we're looking at are going to be comparing sort of observed and expected distributions in your data sets. So one of the things you might want to do occasionally when you're looking at a journal, or if you were looking, maybe designing your own study or something like that, you want to see is like the distribution of the data set that you have, is that normal, or like how would that compare to what you would expect to see on on a different sort of basis there. And so here's an example, one that I think is pretty illustrative of this. There was a study back in 2007, and they were looking at heart disease and why it seemed to be most frequent cause of on-duty death amongst firefighters. And so they're looking to see, like, well, is there a particular time or is there a particular activity that was related more to these deaths? Was it while they're actually fighting fires, or is it really at any point throughout the day, right? And so their null hypothesis when they designed the study was, well, we expect that the deaths occur randomly throughout the work week, and it's not really related to the activity that they're participating in. It could happen at 9 a.m. in the morning, it could happen in the middle of the night, it could happen at any time, right? It's not related to specifically what they're doing. And so what they found was, they used the data, and they found that they determined the expected amount of time that they're performing each activity, and then saying, okay, well, based on the total number of deaths, if you spent 10% of your time doing this, then 10% of the deaths should occur during that time, if it was just truly random. And so here's an example of the data here. And again, we're going to be looking at some charts. I'll kind of go through and explain what each of these are doing. Here we have the duties of what the firemen were doing, whether physical training or alarm response and things like that. They looked at the expected time, so the time, basically percentage out of their day that they're doing all these activities, right? So again, 2% of the time actually fighting fires, 8% doing physical training, all of that adds up to 100%. And so based off of this, based off the total number of deaths, which is 449, they would say, okay, well, 74% of those 449 deaths, 332 of them should occur during the other duties time, right? Based off of the fact they spend 2% of the time actually fighting fires, you would expect 9 deaths to have occurred over the study period. And then they actually have the actual observed numbers here. And so it's very interesting to compare the observed frequency versus what the expected frequency is. And again, I don't think you have to be a statistician to look at the difference there and be like, that looks pretty different, right? Maybe there's something to the fact that they're having a lot more deaths during the fire suppression than they are based off what you would expect to see. And this is a very valuable comparison to make, and say, okay, well, this is what we would expect to see normally, but here's what we're really finding. Is there a true difference there, or is it just random that we're finding this difference? So again, when you're looking at it, the discrepancy seems pretty large between the observed and the expected. And so the first test we can do here is what we call the chi-square goodness of fit test. And it's just comparing the observed versus the expected numbers in each of the categories and telling us if there's a difference, and if there is, is it just due to random chance, or is it very unlikely to be due to chance alone? Okay, and so here's kind of how we're going to be adding up all these different totals, and you're not going to have to do the math on a test for this one, but just to give you an idea of how we're going to be doing these calculations when they actually see them in the actual articles. So again, you'd have your categories here, and this would be the different duties that we saw before. Here's your observed values. You're going to have a totals column here, and then you also have kind of your total overall. And you're going to do this kind of each way, so along the rows, along the columns, and then get a total value over here. And so what that chi-square test is doing is looking at the discrepancies between the observed and expected, and trying to tell us the question that if the null hypothesis were true and there really is no difference between what we're observing and what we would expect to see based off of random sampling, is this distribution just due to chance alone, right? So the null hypothesis say, yeah, it's just due to chance. There's nothing really different here. Even though you see a discrepancy, it's just due to random chance, right? And so you're going to find that if the p-value is small when you come up with this, it means that it's very unlikely that you'd find these differences just due to chance alone. And maybe there is actually something to the fact that different activities for those firefighters was leading to a greater number of deaths there, right? And again, looking at that, there might be something to do with that factor. Maybe the fact that they are possibly being exposed to irritant gases. Maybe they're very physically active, things like that. That you basically reject that null hypothesis and say that that discrepancy there is very unlikely due to chance alone. If the p-value is large, though, you can't reject that null hypothesis, and you just can't say, well, there's a difference here, but it's very unlikely, or it's just due to chance alone that you would find this sort of thing. So what's another way we can actually look at data like this? Imagine you're having say for instance, patients who are exposed to a particular event or a substance or a pathogen or something. Say they were traveling to a certain country where an infectious disease was particularly endemic, and you are comparing those to people that did not have exposure, and then looking at the numbers and rates of people who had the disease versus not having the disease, right? This would be basically your observed values that you're looking at, saying, okay, well, this is what I actually found when I was looking at the data set over, say, a particular time frame. Well, how do you figure out what the actual expected values would be based off of just this data here? Like, how would you expect what would just be due to just random chance alone? And it gets a little complicated, but it's based on the different total columns that you're going to be comparing there, right? So looking to see like what you would expect just just by random chance alone of people who are exposed and had the disease. You can calculate it like this. And again, don't get too lost in the weeds on this one in terms of how to calculate this. This is just how we determine what the expected values would be, so that we can then compare it to what the actual observed values were, which we saw in the last slide. And again, you would just go ahead and get a p-value there and say, okay, well, is this different enough that it's unlikely these differences are due to that chance alone, right? Something else we can do, we can try to compare proportions, right? You're going to see this is done very frequently in prospective, meaning time moving forward, and experimental studies. So some of the different lingo you're going to run into here when we're talking about cross-sectional, prospective, experimental, and then retrospective studies here. So when you're looking at the next two sections, look at the question, does an exposure to something, or say to a risk factor, cause disease? Okay, so it's a lot of times the question we're asking here is, does exposure to mosquitoes cause malaria? Does exposure to alcohol during pregnancy cause birth defects? These are the kind of question to be asking is, does exposure lead to disease occurring? Some of the kind of lingo we're looking at here, incidence, is going to be the rate of new diseases moving forward. And we'll talk much more about this in the epidemiology section of the class later on. But say you were to say you're kind of moving forward in time and detecting the number of people that developed a new disease state, that number of people would be the new incidence over that time frame. Prevalence is where you're basically looking at a snapshot of a population and determining how many people actually have the disease state in question, right? So you could say if you looked at a group of 100 people and say 20 of them have hypertension, well, the prevalence of hypertension in that group is 20%, right? Incidence is looking for new cases going forward, essentially. And so when you're looking at a cross-sectional study, this is basically where you're taking a single sample of subjects, hopefully randomly selected, and you're looking at them without regard really to whether they have the disease or the risk factor, and then they get divided into groups based on their exposure, right? So maybe it was smoking, maybe it was exposure to a certain chemical, maybe it was anything really. And then you would look at the prevalence of disease between those groups, those who are exposed to the risk factor and those who were not, and then comparing between the two to say, okay, well, is the differences in rate of disease due to chance alone, or is it very unlikely that's the case and there may be actually a difference here? Maybe the exposure to that risk factor has some correlation with actually developing that disease. So when we say a prospective study or maybe a longitudinal study, basically this is where you have two groups of subjects that are selected. Typically with these, you're going to be setting out essentially one group that has exposure and one without, right? And then you follow them forward in time to look at the actual incidence of disease in the two groups. With the cross-sectional study, you're using prevalence of disease, and that's actually pretty quick to do. It doesn't take much time to run a study like that. However, prospective studies are much more labor intensive because you have to monitor people going forward in time to look at the incidence of new disease rates between those two groups there. And then with an experimental study, this is where we're actually getting randomly selected people, putting them into two different groups there. And then I, as a researcher, could say, okay, well, you're going to get exposure to this medication and this group is not. And then you look forward for those outcomes there. So this one, the prospective longitudinal study, is a little more kind of a convenient sort of thing where you're kind of lumping people based on their already, whether that categorization of if they're exposed to the risk factor or not, versus here in the experimental study, the researchers are actually causing the people to be exposed to that risk factor or not, as the case may be. So another one we'll get into is called the case control study, and this is going to be more commonly used as a retrospective study where you're going to be looking backwards in time. And so basically we're going to get two groups of subjects that get selected, and we're going to have the one group that has the disease state in question, so say for instance lung cancer, those are going to be our cases, and we're going to match them to people who are very similar to them. So matching females with females, matching people who are in their 70s with other people in their 70s. And then what you're going to be doing is looking backwards in time to determine what were the commonalities in terms of risk factors they were exposed to, right? So you're looking at lung cancer rates and you look backwards to see, well, who are the smokers, right? Were people who are smokers more likely to develop lung cancer? Or more specifically, are people with lung cancer more likely to have been smokers? Or people without lung cancer more likely to have been smokers, right? Let's look at an example of an experimental study. This is actually a clinical trial that was done back in '93, and basically they were looking at the effectiveness of zidovudine, which is a antiretroviral drug used in the treatment of HIV, and they were treating asymptomatic people infected with HIV who had at the time had a normal CD4 cell count. Okay. AZT had been previously been shown to be effective in patients with AIDS, in patients who are asymptomatic but had a low CD4 count. But the question was, well, if I give this to people who already had a normal CD4 count, could I potentially prevent them from having disease progression? And for HIV and AIDS, one of those signs of progression would be a drop in their CD4 count. So that's what they were looking for. So saying, okay, well, if I give these people treatment and these other people no treatment, who actually has progression of disease in terms of dropping their CD4 count, okay? Now, this was a randomized, double-blind, prospective study, right? So kind of breaking that down, randomized just means that the groups are selected at random in terms of whether they're getting exposed to the drug or whether they're not. People who receive the drug, in this case, would be the experimental group. People who didn't are considered to be the control group. They're going to be the comparator there, okay? When I say double blind, this means that basically we did that thing where you kind of poke the patients in the eyes, and then both groups were blinded at that point. I'm kidding. Basically, that means that neither the researchers were aware of which patients were getting active drug, and the patients had no idea if they were getting active drug or not. So very frequently, you'll have it where the patients who are in the experimental group get the actual pill itself, whereas in the control group, perhaps they would get a placebo pill that looks similar, but they couldn't tell the difference if they actually got drug or not, okay? And then prospective means moving forward in time, okay? So you kind of enroll people in the study right then. Either you set up your groups, you give the experimental group the drug, control group no drug, and then you follow them to see who has that drop in their CD4 count. So looking at this, you can see here we have the treatment group versus placebo group. And you can see the number of people who had a disease progression versus no progression. Okay, and if you look at this, you can actually kind of do a chi-square sort of analysis here, right? You can determine what the observed is based off these numbers, and then what the expected might be, and then do a comparison like that if you wanted to. Now, one thing I will note is that depending on the disease state and depending on time, you're going to find that you could never run a study like this nowadays, because to actively withhold treatment from someone with HIV is considered unethical, because now we know nowadays, 20 some odd 30 years later, that this is not appropriate, right? We know that treating patients earlier with HIV does help prevent progression, but at the time we didn't know that. So this is why you can find some of these studies that nowadays would seem sort of abhorrent and would never make it through an institutional review board. But basically, getting back to the trial results, they found that disease progressed in 16% of patients receiving AZT, which is 76 out of 475. And then for the treatment group, they found that the confidence interval ranges from 13 to 20%. So presumably, if you were to, say, extrapolate this out to all people with HIV and you were to give them AZT, the number of people, the percentage that would progress would probably range somewhere between 13 and 20%. You can be 95% sure of that, okay? In the patients who received placebo, they found that 28% were progressed in that case there. So 16 versus 28%. And then in this case for the placebo group, this confidence interval range from 24 to 32%. So what does that mean? Well, looking at this, you can find what we call attributable risk, or we can look at things like absolute risk reductions. You can say like, okay, well, if patients who get no treatment have a 28% chance of progressing. People who receive treatment have 16%. Well, there's an absolute reduction of risk of progression is 12%, right? That's pretty simple. You just subtract one from the other, right? That still doesn't really tell us, though, for instance, was there actually a statistically significant difference, though? And in this case here, when you're looking at the difference in the ranges, when you actually subtract this and get the confidence interval here, you can find that it ranged from, say, 6.7 to 17.3%. And at this point, you get that p-value of less than 0.001. So this risk reduction turned out to be statistically significant showing that it is very likely that if you receive treatment, you are less likely to have that progression and drop that CD4 cell count. Now, because of this, looking at this difference here, you can see here that it could range. It may only be 6.7%, which maybe not be as significant, or it could range all the way up to 17.3% of a risk reduction. Okay. So anyway, so again, if we assume those subjects are representing the larger population of asymptomatic patients with HIV who had a stable CD4 count, we can be 95% sure that we would reduce the risk of progression by giving them AZT between 6.7 to 17.3%. So one thing you can actually determine is also what we call the number needed to treat. So this would be the number of people we would need to give the intervention to in order to find benefit in one patient. Or in this case here, how many patients would I have to treat with AZT in order to determine, or in order to prevent one patient from progressing. Okay, and so what we can do actually is just get the reciprocal of the absolute risk reduction here. So again, 12% was that absolute risk reduction. If I take 0.12, which is 12%, and then flip that over, right? And then we basically get 8.3. And essentially what that means is that for a patient with a stable CD4 count with HIV, I would have to treat 8 patients in order to prevent progression in one patient. Okay. And so by doing that, by getting that number needed to treat, it starts to give you an idea of like, well, how cost effective or how effective is this really? You know, if the number was say 60, that might be a harder thing to make an argument for versus if the number was say 2. For every 2 patients, I'd prevent progression in one of them. That's pretty good, right? Here, you see a number is 8. And so this is where you can start to make some of those value judgments and determining, well, just how effective is this treatment here. When you get the confidence interval for the number needed to treat, it could range, though. It could range from about 6 people up to 15 people that would need to be treated with AZT to prevent progression. Okay. Now, as I mentioned, are higher or lower numbers needed to treat preferred? Obviously lower, right? Lower means you're having much more effective treatment and need to treat fewer patients in order to see that benefit. So the absolute risk reduction, we were looking at subtracting one risk from another. Here's a case where we can use the relative risk, where we actually divide one by the other to get a ratio. And it kind of tells us, you know, by comparing the two, what are the percentage odds of having this progression as compared to getting the placebo. Basically, all you got to do is take that 16% we got before, divide it by the 28%, and we would see that with subjects treated with AZT, they're 57% as likely as placebo to have that disease progression, right? So it's almost, you know, say 0.6, you know, 60% as likely. So you can still see that reduction. It's just another way to state kind of the same thing here. Now, one thing to note with this is when you're looking at relative risk is that it could range anywhere between 0 and 1, meaning that if this was 0, it would mean that there was no risk at all of disease progression in patients who got treatment, versus 1, meaning that there was no difference whatsoever between the two. So again, 28% divided by 28% would be 1, meaning that the relative risk is identical between the two there. I mean, there's no difference, right? When you do a relative risk, you're also going to be getting a confidence interval, which is really important to determine also are the significance here. So here the 95% confidence interval for the relative risk range from say 44% to 74%, right? That means if we were to apply this back to that larger population, that relative risk of getting treatment with AZT would range between that 44 and 74%. So when you're calculating the p-value, you're always starting off with a null hypothesis. And in this case here with this study, you'd say that AZT does not alter the probability of disease progression, right? You'd say that there's no difference between the groups. It doesn't matter if they got AZT or placebo, no difference there, okay? And so when we find a p-value, especially a low p-value, what it's telling us is that there is a true difference, that by giving someone AZT, you are less likely to have them develop a disease progression, okay? And again, that p-value is also telling us what are the chances that by comparing these two groups, we would find this result by chances alone, right? And so, again, you're also going to find that the p-value can be, you know, dependent on things like the sample size and then how far the relative risk is from 1. When they actually calculated it here, they found that it was less than 0.0001, meaning it was very, very, very unlikely that by giving the patients AZT that you had no impact on the disease progression. We did see that there was less disease progression because of the intervention of the AZT here. Because of this p-value, we can then reject that null hypothesis and say that, yeah, there is a true difference between these groups because it is so unlikely we would be able to find results like this just by chance alone. So let's look at comparing proportions, but now instead of using one of these experimental studies, let's use a case control study. And remember, we said case control studies are going to be usually retrospective, and they're usually going to be grouping patients based off whether or not they have the disease state in question, and then looking backwards in time to see were they exposed to a risk factor or not. Here's an example of a case control study that was done back in 2005, and it was asking the question, does the cholera vaccine work? And basically they had this cholera vaccine and trying to determine the efficacy of it. And so they did a case control study that was retrospective. And what they were doing is they were comparing people who had cholera versus those who did not have cholera. And then they looked backwards in time to see who got the vaccine and who didn't, right? What you would think is that people who got the vaccine, or people who had cholera, were less likely to have received the vaccine, and people who did not have cholera were more likely to have had the vaccine, right? The null hypothesis, though, if you think about it, would be that there's no difference between the groups, and that there was no difference in vaccination rates between those that either had cholera or those that did not. So looking at the data here, we can see that those that received the vaccine and those that had no vaccine, and then again how we're organizing our group is based off those that had cholera versus not. So here are the cases, here are the controls we compare them to, and then looking at the rate of vaccines, whether they got them or not, right? One important thing to note here as well is that normally when you're doing, say, like a prospective experimental study, you generally want the sample sizes to be roughly the same. You wouldn't want 10 people in one group and 100 people in the other. You want them to be pretty similar. Here with case control studies, one thing that we like to do is to use multiple controls for every case that we have, which is why you end up seeing that there are so many more control cases than you are having, or controls than you do actual cases here. The reason why we do this is to make sure that we have a good comparison and that we're trying to rule out the fact that our cases may be an outlier, right? By comparing them similarly to other controls who have similar characteristics like similar age, gender, socioeconomic status, etc. You make sure that they're pretty similar, and that way these outliers can kind of be accounted for. So looking at this, it's important that you don't try to calculate the relative risk from a case control study. It's not really going to be that effective there because, unfortunately, we don't really have an idea of what the entire population of people that could be at risk for getting cholera or not. And so because you can't really look at incidence because you're not moving forward in time, you're dealing more with prevalence, right? And so because of that, getting a relative risk just turns out to be invalid. You really can't do that. It's better to use incidence and relative risk and things like that with a prospective study. Here instead what we're going to be using is what we call the odds ratio. And so it's kind of looking at the comparison between probability versus odds, and sometimes I still have a problem kind of setting this straight in my head. But basically the probability that an event will occur is the fraction of times you expect to see that event in as many trials, right? So it can range from 0 to 1. So again, if you see something happen 25% of the time, that's the probability that it's going to occur. Odds are slightly different, and this is mainly to do with the denominator changing between these two values here. It's going to be the probability the event will occur divided by the probability that the event will not occur. Okay, so here you're going to find your denominator for probability is going to be the total number of trials that you ran versus, and the odds is going to be basically the probability that the event does not occur. And I'll give you an example of what this looks like in a second. You can make a conversion here. We're not going to have to do that on the test, but just know that it is possible that you can actually make these conversions. So let's look at an example of a horse running some races here. Let's say that the horse runs a total of 100 races and wins 25 times. The probability of winning is going to be the number of times that the horse did win divided by the total number of times it ran. So the probability of it winning is 25%, right? The odds of it winning is a little different here. So it's going to be the probability of it winning the race versus the probability of it not getting or not winning that race there. So here you see the probability of 25% is going to be the numerator. The denominator is going to be the probability of it not winning, which is basically 1 minus the probability of it winning. And you end up getting 0.75 in your denominator. So 0.25 divided by 0.75, and basically that ends up being about a third, right? So 1 win to 3 losses essentially, right? So it's kind of getting that ratio there. That's what we call an odds ratio. So really the important thing for you to know is that for retrospective studies, typically odds ratios are going to be used much more commonly. For prospective studies, you tend to find that the relative risk is going to be used much more commonly. So let's look at the odds of the cases versus the controls being vaccinated. So among the cases, the odds of them being vaccinated is 10 to 33. So the odds of someone having cholera and being vaccinated is roughly a third. The odds of the controls who did not have cholera of them being vaccinated is 94 to 78, or if you divide that out, it's 1.205. Okay, so here are the individual odds. Now to get the odds ratio, it's pretty easy. You just divide one by the other. So the odds of the cholera group, the cases being vaccinated versus the odds of the controls being vaccinated equals 0.25. Okay, and then you can also get a 95% confidence interval for that odds ratio. So looking at it, we can conclude that vaccinated individuals are 25% as likely to get cholera as unvaccinated people. What does that mean? Well, it means that these people are actually protected from getting cholera because their odds of getting it were much less, 25% as likely as the unvaccinated group there. Okay, and so in this case here, the vaccination studies, it makes sense to subtract the odds ratio from 1 to say that basically the vaccine is 75% effective in preventing cholera. So you can see here when we're trying to interpret the p-value, the odds ratio and the confidence interval generally going to be accompanied by that p-value, but frequently you actually don't even need the p-value to tell you whether or not it's going to be significant. I'll show you some tips on how to do that. But here, as we mentioned, the null hypothesis would tell us with a case control study that between the cases and the controls, the vaccination rate would be identical between them, or they would be not statistically significantly different. However, what we found was the p-value is actually 0.003, right? So there's only a 0.3% chance that we would find a difference here in the vaccination rates between the group just due to chance alone. So because that is so small, we would be able to say that, well, it appears that if patients are vaccinated, they're less likely to get cholera, right? Now, it's interesting here. Note, we talked about two-tail versus one-tail p-value tests a while ago. Having a two-tail test is important for this one because there's a possibility. What if the vaccine was maybe made improperly, or maybe it caused the disease in patients? You have to account for that because we may not know which one we would assume which mean to be lower. And so here you'd want to use a two-tailed test just in case something was wrong with the vaccine and actually caused cholera in these patients. So there's a couple of advantages with case control studies. One, that they're relatively cheap and quick to do. It's basically just looking back in time. A lot of chart reviews are done this way. As an example, you can just basically go through medical charts, pull data, and be able to run a case control study relatively simply. There's some challenges though, right? So one, to pick the right controls. How do you pick people that are truly similar to your cases there? And there's even some problems where you can pick them where they can actually be way too similar, and it's really hard to find any differences between them. But it's important to try to control for those extraneous factors that might confuse the results, right? So looking at things like immunosuppression in the case of like vaccine studies, right? Not control away things that we would look for though in terms of effects, not to control away what their vaccination status was, because that's specifically what we're looking at. And then how do you know to accept the results? Well, results tend to be more likely true if the odds ratio is pretty large and when the results can be repeated, right? And oftentimes what you're going to find is that we will do case control studies retrospectively to kind of generate some ideas. And if we see some trends there, then we can then turn it around and try to do a prospective study to see if it actually bears out when done looking at new incidents of disease rather than just looking at the prevalence. Up next, how do we compare two different means together? This is where we're going to get into our unpaired t-test. So this is going to seem like an odd sort of study here, but it's a pretty decent example of where we're going to be using a t-test here. Keep in mind this is going to be an unpaired t-test. We'll talk about paired t-tests a little bit later on. But what we're looking at today is going to be the maximum relaxation of bladder muscles. Hopefully I didn't stimulate anyone to need to use the restroom perhaps. But looking at this, what we're seeing is that by using an unpaired t-test, we can compare the means of two different groups. And assuming they're coming from a Gaussian distribution, we can see is the differences there likely due to chance alone, or are there truly a statistically significant difference between them? So this is a study where basically they were looking at bladder muscle tissues. I believe they were coming from rats, and they were giving the neurotransmitter norepinephrine to see how much relaxation they were finding there. And what they wanted to do was to compare old versus young rats to see, does the bladder relaxation that occurs after exposure to norepinephrine differ based on the age of the rats there? Or is the differences they observe just due to chance alone, and age doesn't really have a big impact? So here you can look at the results, and again, it's not important that you have every single bit of data there. It's important though is that what you can do is interpret the results you actually find once you're reading them in a journal article. And so here we can look at the old rats and looking at the percentage of Emax of that bladder relaxation and what it would look like based off of this. It looks like the young rats had more relaxation in their bladders as with exposure to norepinephrine than the old rats here. And we can now do comparisons. We can do a t-test between these two different means and determine if the p-value is high, meaning there's really no difference between this group, or is there a significant difference. So looking at the unpaired t-test, and we'll talk about paired versus unpaired in a moment, the p-value ended up being 0.003, meaning it was very unlikely that the differences in the means there were likely to be due just to pure chance alone. Okay. Now here, notice we used a two-tailed test, and that's because a priori they didn't know whether or not the old rats or the young rats would have the higher or lower mean, and so by using a two-tailed, you kind of give yourself a little bit more robust statistics. You're not assuming that it's going to go one direction or the other. And some different ways you can look at this, looking at the confidence intervals. So doing the differences between the means here, you can show this in different ways. So here's the mean, and kind of using it as a bar graph. More often than not, you're going to frequently find that you'll have the mean with the mean difference, and you're going to find the confidence interval there being expressed as well. And so how do you interpret the results from an unpaired t-test? Well, basically looking at the results here, you would see that the mean maximum response in the old rats was 23.5, lower because you subtract one mean from the other, and that confidence interval was 9.3 to 37.8, meaning that if you were to say extrapolate this data out and looking at these old rats, you could say that it may range anywhere between 9.3% lower, or it may range all the way up to 37.8% lower, right? So because of that, this is kind of saying with 95% confidence, I can say that this would what the results would be if I were to do this and extrapolate this, say, to more rats, essentially. One of the things to note here, which I think is important, is how wide your confidence interval is. Note here that a very wide confidence interval means that there's a lot of variability in the data, which means it can range pretty widely. And here you can see between 9.3 to 37.8. It's very possible, especially with larger sample sizes, you can tighten up that confidence interval, and it may range, say, anywhere between 20 to, say, 27, right? That could be a possibility. But one thing to note here is when you're subtracting one mean from another, if there was no difference between the two, that subtraction would just equal 0, right? 10 minus 10 is 0. So one thing you're going to see here is when you're doing a mean difference, if your confidence interval includes 0, that means it can't be statistically significantly different, and your p-value is going to be greater than 0.05. So here you can see this does not include 0, and so because of that, we can already assume that the p-value is going to be less than 0.05. Okay. And again, looking at this, we can see the p-value ended up being 0.003, which makes total sense based off these confidence intervals. And we'll look at some more examples of this going forward, and this will become more clear the more we practice this, especially during the journal clubs. And again, our null hypothesis would be that the data between the two age cohorts of rats would be the same, they have identical means, but since we found this result, it is very unlikely that finding a difference this large is due to chance alone. So there must be a true difference here. So when you're using an unpaired t-test, you have to make several assumptions when analyzing the results here. So one, it should be a random or a representative sample, and this normally means you have a normally distributed set of data when using the unpaired t-test. The other thing that makes it unpaired is the fact that you're using independent observations, right? So this would mean that you're not using the same rats in the two different groups. You're not using, say, sibling rats, or you're not using, say, a mother and child. You're using independent observations here. Okay. Other things, the data should be accurate, which you would hopefully assume there is true. And then, as I mentioned, it should be distributed in this Gaussian manner here. Okay. And again, typically you want to see that both groups have a pretty similar standard deviation, even if the means are distinctly different. That shows that the variability is roughly similar between the two groups there. Well, what if I wanted to compare two paired groups instead? Well, at this point, I can then use a paired t-test, right? And so it's going to be much more appropriate if I was, say, using a same person twice. So I said, say, a pre and a post analysis. If I use siblings, if I use anyone who are, say, genetically related at all, that's where you're going to find that paired groups can be used there. The main point is that by using a paired test, you're showing that there's some relationship between the groups that are being compared, and you're trying to account for that basically. Okay, don't use a paired t-test for an unpaired set of data, and vice versa. You wouldn't want to use an unpaired t-test for groups that have some relations to one another. So this is kind of what I talked about already, is that when you're using a matched or paired test, examples of this would be, say, pre and post analysis, where you test someone prior to an intervention and then after an intervention. If you recruit a subject as a pair, or you're matching for certain variables, would be one thing. The twins or siblings is probably the most obvious example. And then also if you're having the same measurement, or say the same subject but having measurements done via different methods. So if you can imagine having an automated machine testing blood pressure versus manual auscultation, it's the same person. Presumably they have the same blood pressure, but you're looking at the differences between how it's actually being measured. But because it's in the same person, you have to do a paired test. So some examples of a paired t-test. Here's one from a very recent article back in 1876. Darwin was actually looking at the growth of seeds that were either self-fertilized or those that were cross-fertilized. And basically what they did was they compared seeds in each of the groups together, and they kind of planted them as a pair to make sure that any changes in soil temperature or sunlight were the same between them. But because they shared the same environment, they considered that they would need to do a paired test there. And they're basically looking at the differences in growth rates between those that were cross-fertilized and those that were self-fertilized. So basically everything else was taken into account. Everything was the same between them in terms of variables, but you're looking just at this one particular factor here. And so looking at the difference here in terms of the matched measurements, you can start to look for any significant differences between the means there, but using like a paired t-test would be really appropriate here, since the different samples were being paired, right? So you're then comparing the heights between the groups here. And just different ways you can actually show that difference. So again, using things like the standard, the mean, etc., can be ways to kind of express the data there. But the important thing to note would be looking at the paired t-test between the two there, and they were actually seeing that it looked like if you're having this cross-fertilization, they did appear to have higher heights, so they're growing more, and this was just barely statistically significant, right? And again, they used a two-tailed test because they weren't sure which one were actually going to have the higher means, and so by using that two-tailed test, again, that makes it a little bit more robust. So when you're interpreting the results of that paired t-test, again, it's looking for the same thing as what you saw with the unpaired test. It's just a matter of what your subjects are in terms of their relations to one another. And again, what they found was the mean difference here between the cross and self-fertilized is about 2.62 inches, 15% or so. And then when you actually got the confidence interval for that, it ranged anywhere from between 0.003639 inches all the way to 5.2 inches. Now that's really close to zero. And remember that our level of significance there was if it crosses zero, because we're just subtracting one mean from another. So because of that, it was very barely close, or very could range anywhere between a difference of 5 inches to almost nothing. And so because of that, you saw that it just barely achieved significance. It was like 0.049 something, so very, very close to the cutoff point. And again, it may not really be that clinically significant of a difference depending on what the case is, right? And notice here it's a very wide confidence interval, showing there's a lot of variability in the data, especially if you were to extrapolate that out back to the general population. Now, remember the p-value when you're having a paired test would be that there's no difference between the groups, but we were able to reject that because the p-value was 0.0497, just barely. But remember, we used that two-tailed test, so it was a little bit more conservative, more robust, because we weren't sure which one would actually have the higher mean. So next, let's look at the idea of correlation. I'm sure you've heard the old adage, correlation does not mean causation, right? Well, we can look at two different variables and try to determine kind of how they relate to one another, how they correlate with one another. As you change one variable, how does the other variable change there? And here's an example of what we're going to be looking at. And again, one of the things we'll see here is what we call a correlation coefficient, and that's going to be identified by the variable r. And so that'll be important as we are looking at this a little bit more. So here's a study that was done by Borkman, very good researcher name, but Borkman et al. Was back in 1993. They were hypothesizing that depending on the lipid composition of your cell membranes of the skeletal muscle, it would affect the sensitivity of that muscle for insulin, right? So they're saying that based on lipid content and how that changed, there would be a change in the skeletal muscle sensitivity for insulin. And so they did a relatively small study, only 13 healthy men, and they were infusing insulin at basically a standardized rate there. And then they quantified how much glucose was needed to maintain a constant blood glucose, right? The higher glucose needed would show more sensitivity to insulin because you're uptaking more of that glucose, and then lower glucose needs would indicate more resistance because not as much of it was being taken up in that skeletal muscle. So then what they did was they did a muscle biopsy and they looked at the fatty acid composition and compared that to the glucose needs to see, basically as an indirect measure, what the insulin sensitivity was there. Okay. And they wanted to focus on the polyunsaturated fatty acid content of between 20 and 22 carbon atoms large. So when you actually compare the two variables together, you're going to find there's going to be some scattering of the data there, right? Hopefully, when you look at the graphs, you'll see there's going to be some trends in terms of the actual the correlation between the two there. So looking at these, you're going to find that each of the values will have a coefficient of variation, and it's important to kind of explain like why that variability is there. And the reason why that is oftentimes because of external sort of influences here. The fatty acid content is probably not the only thing that has any impact on the insulin sensitivity. And so because of that, there's going to be a lot of variation. And so what we're going to see when we look at the graph is that there will be a pretty clear relationship between the two variables, and that the tighter that line is, the more correlation there is between the two there. Okay. So here you can find the actual data points here between the fatty acid content and the insulin sensitivity. And here you can look at this graph and you can look to see how each of these are being plotted together. And one thing you want to note here as well is that you can kind of see a trend that as the fatty acid content goes up in general, and again this is going to be my best fit line, which is probably not quite accurate, but as the fatty acid content goes up, typically insulin sensitivity was going up as well, right? Again, you can find lines that go in other directions. You may find one that goes this direction or maybe it goes in this direction. It all just depends. But for this one in particular, you find that, okay, there's a definite trend here where you see there's a correlation going as fatty acid content goes up, insulin sensitivity is going up as well. So that direction and the magnitude of that linear correlation can be quantified by that value R, as I mentioned, that correlation coefficient, and it can range anywhere between -1 to 1. Okay, and so just to give you an idea what that looks like, if I was to draw this out, if you were to have a value of 1, that typically means that as one value goes up on the x-axis by 1, you're going to find that the y-axis should go up by 1 as well, right? So it would be a perfectly straight line heading right up. If I were to have no relationship between the two whatsoever, let's say for instance, there was just no relationship between, even as the fatty acid content goes up, no real discernible change could happen between the and the insulin sensitivity, that would be a coefficient of 0, meaning there's no relationship, there's no correlation whatsoever. It would be just a straight flat line. And then a negative value, let's say we have -0.1, find another good color to use here. Let's say we'll just go with something closer to white. We'll say if there's a negative value, it means that as the value of x goes up by 1, the value of y should go down by 1. So you typically see a downward sloping line like this. Now again, it's not always going to be quite as clean as that, but in general that's what that means. So the red line is a correlation coefficient of 1, the green line is 0, and the yellow line is -1 there. Okay. Again, if it's positive, it means the variables tend to increase or decrease together. If it's negative, it means the variables are inversely related, so that as one goes up, the other one's going to be going down there. Okay. In our example, we saw that it was generally going up, and it had a correlation coefficient of 0.77, which makes sense because that kind of drives with the fact that it's a positive number. As fatty acid content went up, you found that the insulin sensitivity went up as well. And again, some graphs kind of showing you what this might look like. A value of -1 just indicates that you see here that as one value goes down, that's actually a pretty poor color to use for that. That as one value goes down, you're also going to find the other value is going to be going up and vice versa. So again, this is inversely proportional. Here would be one that's kind of indeterminate, where it's kind of, you can tell there's a trend, but it's not going to be quite as clear. And then notice as the values get closer and closer to 0, the scattering gets much more just random, it looks like, right? Where there's no relationship between the two variables together. Versus once you start to get more into the positives here, you start to see a little bit more obvious of a trend, right? So it gets more and more tight as the numbers go up. And if it's a total value of 1, that means that every single value is going to line up on that nice straight line there. Okay. So again, if it's more scattered like that, kind of like buckshot or something, you're going to see that the value's going to be closer to 0, where there's no linear relationship. So, and you can actually get a confidence interval for these as well. So when you're looking at the correlation coefficient, you can see like, well, is the correlation that we found, is it just due to random chance? And oftentimes you'll find that the confidence interval gets reported here along with a p-value. And here you see it's 0.0021, so it's very unlikely that the correlation we found was that there was much due to chance alone, essentially, right? If there was really no difference between, or no correlation, we would assume that the R value would be 0. But since we were able to find this p-value of less than 0.0021, we can definitely say there was probably a relationship there. It's very unlikely that relationship was just due to chance alone. Now it's two-tailed. And why is it two-tailed? Well, because before doing the study, you might not know, was it going to be a positive correlation coefficient or was it a negative correlation coefficient? Okay. And again, you can reject the null hypothesis because, again, it's very unlikely due to that p-value that this is due to chance alone. So we talk about correlation and causation, and again, just because something correlates together doesn't mean that one causes the other. You may find that two variables relate very well, and it could be related to some other factor, right? It could be related to some other hormonal factor or genetic factor or something like that. It's very difficult when just looking at how two variables correlate together to say, like, okay, well, one obviously caused the other. And there's some other tests we'll look at later on that will kind of tell us more information about that. But again, other things might play a role here, right? It could be a very complex system. You're just looking at two components of it, and there could be a lot of external factors, as we mentioned. Just because there's a correlation does not necessarily imply that one causes the other necessarily. Just an example, you can have two variables that are correlated together but have no actual direct causation. So there's a study done one time where they showed that having an increased number of telephones per capita increased life expectancy. I don't know that normally having more phone access necessarily increases life expectancy directly, but maybe there could be something there. But for the most part, you can find these things and they have just no relationship whatsoever. But like every other test, we're going to find there's some assumptions we're going to be looking for. When you're doing this, you want to make sure that it's a random sample. So you're pulling from a random population that you're interested in, and it should be a paired sample, right? So this is a case here where you want it to be the fatty acid content from patient A should be the same insulin sensitivity you're comparing it to for patient A, right? It should only be from one population, and each of the observations themselves should be independent, right? So that way patient A and B's values don't get mixed up there. Make sure that how you calculate an X value or a Y value they're not kind of dependent on one another. So that way, like, say for instance, you're correlating serum creatinine to creatinine clearance. Well, creatinine clearance is calculated from the serum creatinine. It really wouldn't make a whole lot of sense there. You're also trying to assume this is a Gaussian distribution, as we mentioned, and that the covariation is linear. There's not going to be a curve to it. That gets a lot more complicated outside of our scope here, but that's kind of one of the assumptions you're going to be dealing with, and hopefully there's no outliers, which we know that you can do tests for that. One thing we're going to get into in another section here is what we're going to call the R-square value. And so basically the square of the correlation coefficient. And it's actually a little bit easier to interpret than R, where R could range from +1 to -1. This one is actually always going to range between 0 and 1, basically because it's, any negative number that is squared is always going to be positive, and any positive number squared is going to be positive. So it's always going to be between 0 and 1. And this is basically going to be the fraction of the variance that is shared between the two variables there. And so again, the higher your R value is, obviously the higher your R square is going to be, as we'll see in another section. And again, when talking about correlation, here we're using it in the very strict sort of statistical meaning. It means quantifying the association between two variables. Note here they need to be continuous. This would not be appropriate for like an ordinal variable or a nominal variable. However, you typically hear correlation kind of being used a little bit more generally for the most part. And just know the coefficient of determination is just another name for that R square value. So let's look at a few questions to end up here. Can a t-test be computed from the mean, standard deviation, and sample size of each group? Yes, you don't need actual raw data to do any of that. Very frequently, studies are not going to express all of the raw data. You just need the mean and standard deviation sample size, and you're good to go. Why is it called an unpaired t-test? Well, it's basically going to be between groups that have no relationship together. They're not matched. You're going to find that a paired t-test is always going to be a little bit more powerful. It's not going to be quite as robust, but this is why we want to make sure we're following the assumptions of an unpaired t-test first. Does it matter whether two groups have different numbers of observations? Not necessarily, right? You'd like to have a similar number of n, but to run a t-test, they don't have to have the same n. Typically, you're going to find that when you have similar sample sizes, that you're less likely to abuse any of those assumptions we were talking about if they're going to be a little bit more equal. Can I decide how the subjects are matched after collecting the data? No, this is not smart. This is where you want to design study protocols before you actually start to collect data and enroll patients in your study there, right? It's part of that multiple comparisons trap we were talking about before, where you just kind of run the data in different ways until you find something that works. Does it matter which variable is called X and which one is Y when you're doing correlations? No, not really. They're kind of going to be interchangeable in terms of those calculations. Can R be negative? Yeah, absolutely. When you have an inversely proportional sort of change there, you're going to find, or inversely related correlation, you're going to find that value, that line's actually going to be moving down and to the right there. Just means that as one value increases, the other one's going to be decreasing, and vice versa. Now, what if I double the number of points, but R doesn't change? What happens to my confidence interval and the p-value? Typically, they're going to get more narrow, because as you get a bigger sample size and the R doesn't change, just means you're going to get much more narrower CI because you're getting closer to that population total. So if you have any questions, let me know, and I'll see you guys around. Thanks so much. Bye.